What I'm about to tell you could change how you think about the pill sitting on your nightstand right now. Every morning, millions of seniors take Amlodipine for their blood pressure. They trust their doctor. They trust the medication. They take it faithfully, day after day, year after year. But here's what terrifies me. Most of those people have no idea what's really happening inside their bodies when they swallow that small white pill. They don't know about the side effects their doctor mentioned in a rush during a 7-minute appointment. They don't know about the dangerous interactions hiding in their medicine cabinet. They don't know why some people feel terrible on this medication while others feel completely fine. And they definitely don't know about the things that happen over years of use that their doctors simply never explained. I'm Dr. Eliza Wright, and I need to tell you some truths about Amlodipine that the pharmaceutical companies and even many doctors don't emphasize enough. By the end of this video, you're going to understand exactly what this medication does to your body, why it works for some people and fails others, what symptoms you should never ignore, and the critical information your doctor probably didn't have time to give you. This isn't about scaring you. This is about empowering you with knowledge so you can have a real conversation with your healthcare provider and make decisions that actually protect your health. So let's start with the most important question. What exactly is Amlodipine doing inside your body? I'm Dr. Eliza Wright, and before we begin, please subscribe to my channel for heart guidance that helps you protect your future every single day. That is exactly what I'm addressing in this video. Because the truth about Amlodipine is that doctors hand out this prescription like they're handing out candy. It's one of the most commonly prescribed blood pressure medications in the world. Over 70 million prescriptions written every single year in the United States alone. And most doctors, when they prescribe it, they say something like, "This relaxes your blood vessels. It'll lower your pressure. Take it in the morning." And then they move on to the next patient. What they don't tell you is the full story. And the full story has several chapters that absolutely need to be in your awareness. So let's start with the mechanism. How does Amlodipine actually work? I'm going to explain this in simple terms because you deserve to understand what's happening in your body. Amlodipine is something called a calcium channel blocker. Now that sounds complicated, but here's what you need to know. Your blood vessels, the arteries and veins that carry blood throughout your body, those vessels have muscle cells in their walls. Those muscle cells need calcium to contract. When calcium enters these muscle cells, they squeeze tighter, and that squeezing makes your blood vessels narrower. Narrower vessels mean higher pressure, like squeezing a water balloon. Now, Amlodipine blocks the calcium from entering those muscle cells. When the calcium can't get in, the muscles relax, the blood vessels widen, pressure drops. It's actually brilliant from a pharmacology standpoint. You're essentially forcing your blood vessels to relax by blocking the signal that makes them squeeze. But here's what your doctor probably didn't explain. That relaxation effect doesn't just happen in one place. Let me tell you about Martha. Martha was 68, a retired teacher, very active, loved her morning walks, kept her garden beautiful, traveled with her husband. When she started Amlodipine, everything seemed fine at first. Her blood pressure dropped beautifully. Her doctor was very happy with her numbers. But after about 3 months, Martha noticed something strange. Every time she tried to take her morning walk, she'd get this wave of dizziness so intense she'd have to sit down. Her legs felt weak. She'd feel like she might faint. She'd stand there gripping a tree or a fence post, waiting for the dizziness to pass. Now, Martha was an intelligent woman. She knew her own body, and she knew this wasn't normal for her. She went back to her doctor and said, "Something's wrong. I can't walk like I used to. I'm dizzy all the time." Do you know what her doctor said? He said, "That's probably just your blood pressure dropping too much. Let's reduce the dose." And they did. The dizziness improved slightly, but didn't go away completely. Martha lived with it for another year before she finally came to see me. And when I heard her story, I immediately recognized what was happening. Amlodipine was lowering her blood pressure, yes, but it was also causing something called vasodilation-related hypotension. When you widen blood vessels systemically, you create more space for blood to pool. And when you're standing, especially when you're walking and moving, gravity pulls blood down into your legs and abdomen. Your body has to work harder to push blood back up to your brain against that gravity. If your blood vessels are too relaxed and dilated, that process breaks down. Not enough blood reaches your brain. You get dizzy, you feel weak, you might even faint. This isn't just about your blood pressure number being low on the monitor. This is about your body literally struggling to maintain adequate blood flow to your brain when you're upright. Martha was experiencing exactly that. Her readings might look great on paper, 115/70, but she felt terrible because her body couldn't maintain proper perfusion in her daily life. The solution wasn't just reducing the dose. It was understanding that for some people, amlodipine causes an exaggerated vasodilatory effect that creates problems even at lower doses. Now, before I continue, I want to be absolutely clear about something. Amlodipine is a good medication. For many people, it works beautifully. It lowers blood pressure effectively. It reduces the risk of stroke and heart attack. It has a decent safety profile. I'm not trying to scare you out of taking a medication that might be helping you. What I'm trying to do is give you the complete picture so you can have an intelligent conversation with your doctor and recognize side effects when they happen. Because here's what I see constantly in my practice. Patients who suffer in silence. They assume that feeling terrible is just part of getting older. They think the dizziness is normal, the ankle swelling is normal, the fatigue is normal. They never mention it to their doctor because they figure it's not related to the medication, or they're afraid their doctor will tell them there's nothing to be done. I'm here to tell you there is almost always something to be done. You just need to know what questions to ask. So let's talk about the ankle swelling more specifically because that is the most common side effect of amlodipine. I mentioned Richard earlier. His experience is incredibly typical. The medical term is peripheral edema, and it happens because amlodipine dilates the arterioles, the small arteries in your extremities, more than it dilates your veins. When that happens, you get a mismatch in pressure. Blood flows easily into your feet and ankles through the dilated arteries, but the veins aren't dilating at the same rate, so the blood has trouble draining back out. It pools in your lower extremities. Fluid leaks out of the blood vessels into the surrounding tissue. You get swelling. Now, in most cases, this isn't medically dangerous, but it is uncomfortable. It changes how your shoes fit. It makes standing and walking painful. It can make your skin stretch and feel tight. Some people get a heavy, aching sensation in their legs by the end of the day. And here's what many doctors don't tell you. The edema from amlodipine is often dose-dependent. The higher your dose, the more likely and more severe the swelling. If you're on 10 milligrams and your blood pressure is well controlled, but you're struggling with significant ankle edema, asking your doctor about reducing to 5 milligrams while adding a second medication might solve both problems. That's a conversation worth having. But there's another type of edema that your doctor may not have explained to you. It's called pedal edema when it affects your feet, but there's also facial edema, specifically periorbital edema, swelling around your eyes. This is less common, but it happens. And if you wake up one morning with puffy eyelids and you have no history of allergies or sinus problems, it could be the amlodipine. Some patients also experience what's called gravitational edema that gets worse when you're standing or walking for long periods and improves when you lie down. This all falls under the umbrella of calcium channel blocker side effects, and it's something your doctor should be monitoring you for at every visit. Now let me shift gears and talk about something even more important than side effects. Let me talk about drug interactions. This is an area where I see dangerous gaps in patient knowledge constantly. When you start amlodipine, your doctor probably told you to avoid grapefruit juice, right? Did they explain why? Most doctors say something like, "Don't drink grapefruit juice with this medication," and they leave it at that. Let me tell you what actually happens. Grapefruit contains compounds called furanocoumarins. These compounds inhibit an enzyme in your intestine called CYP3A4. That enzyme is responsible for breaking down amlodipine and many other medications. When grapefruit inhibits that enzyme, more amlodipine enters your bloodstream than your doctor planned for. Your carefully calibrated 5 milligram dose becomes effectively a 7 or 8 milligram dose. Your blood pressure drops lower than intended. You might get severe hypotension, you might get dizziness, your kidneys might be stressed. This isn't theoretical. This interaction has sent people to the emergency room. And it's not just grapefruit juice. Grapefruit segments, grapefruit pulp, any grapefruit product can cause this. Some doctors extend this warning to Seville oranges, pomelos, and tangelos, but grapefruit is the main culprit. But here's where it gets really complicated. Grapefruit isn't the only CYP3A4 interaction. Many common medications also inhibit this enzyme or are metabolized by it. And when you combine them with amlodipine, things get unpredictable. Let me tell you about George, not the George from my other video, but a different patient, 75, who was doing well on amlodipine for about a year. Then he developed atrial fibrillation, a heart rhythm problem. His cardiologist prescribed diltiazem, another calcium channel blocker, to help control his heart rate. Now, George's primary care doctor didn't catch the problem immediately, but I did when he came to see me. Combining amlodipine with diltiazem is essentially giving him a double dose of calcium channel blocker. Both medications affect the same pathways. The combined effect can be synergistic, meaning the total effect is greater than just adding them together. George was experiencing severe hypertension, extreme fatigue, and heart rate that was running too slow. We had to adjust his amlodipine dose downward significantly to accommodate the diltiazem. This is exactly the kind of interaction that can slip through the cracks when multiple doctors are prescribing for the same patient without communicating properly. And it's exactly the kind of thing you need to advocate for yourself about. Statins are another common interaction. Many seniors with high blood pressure also take statins for cholesterol management. Amlodipine actually increases the blood levels of simvastatin and, to a lesser extent, other statins. This means if you're taking amlodipine along with simvastatin, your effective statin dose might be higher than your doctor intended. Higher statin doses mean increased risk of muscle problems, the condition called statin-induced myopathy that can cause severe muscle pain and, in rare cases, kidney damage. If you're on both medications, your doctor should be monitoring your liver enzymes and asking you about muscle pain or weakness at every visit. Now, I want to talk about something that almost no one discusses when it comes to amlodipine, and that's the issue of tolerance. Here's what I mean by that. Some patients, especially those who've been on amlodipine for many years, notice that it becomes less effective over time. Their blood pressure starts creeping back up even though they haven't changed their dose or their diet or their exercise routine. What's happening? Well, the leading theory is something called compensatory mechanisms. Your body is intelligent. When you force your blood vessels to relax with amlodipine day after day, month after month, year after year, your body sometimes tries to compensate by activating other systems that raise blood pressure. Your sympathetic nervous system might become more active. Your renin-angiotensin system might kick in. Your body essentially learns to work around the medication to maintain what it considers normal blood pressure. This isn't universal. Many people stay well controlled on amlodipine for decades. But a significant subset of long-term users develop tolerance, and if your doctor isn't monitoring for this, you might be walking around with inadequately controlled blood pressure and no idea why. Regular monitoring, watching for trends over time, being willing to adjust doses or add complementary medications, these are things your doctor should be doing, but sometimes don't, because they're just refilling the prescription without really examining your current situation. I also want to address something that I've seen become increasingly common, and that's people who stop taking amlodipine suddenly. Maybe they ran out of pills and couldn't get to the pharmacy. Maybe they felt so terrible they decided to just quit. Maybe they read something online that scared them. Whatever the reason, stopping amlodipine abruptly is dangerous, and I need you to understand why. Amlodipine has what's called a long half-life. It stays in your system for a relatively long time compared to some other blood pressure medications. But when you stop taking it, the effect doesn't stop immediately. Your body, which has been compensating for years while on the medication, now finds itself with no calcium channel blocker effect. The compensatory mechanisms that were holding your blood pressure down are now unopposed. Blood pressure can spike dramatically. This is called rebound hypertension, and it can be severe enough to cause a stroke or a heart attack. If you want to stop amlodipine, you need to taper off gradually under your doctor's supervision. Never stop suddenly, never run out and go without. If you have trouble affording the medication, if you're experiencing intolerable side effects, talk to your doctor about a safe tapering plan or an alternative medication. Now, let me address one of the most important things I want to talk about today, and that's the issue of effectiveness. Why does amlodipine work for some people and not for others? Why do some patients get their blood pressure perfectly controlled while others seem to still struggle even on high doses? This is actually a fascinating area of pharmacology that your doctor may not have explained. Amlodipine works by blocking calcium channels, but the specific calcium channels it blocks are L-type calcium channels. Different people have different densities of L-type channels in their blood vessel walls. Different people have different activity levels in the compensatory mechanisms I mentioned. Different people have different genetic variations in how they metabolize the drug. A medication that works beautifully for one person might be inadequate for another, not because of anything they did wrong, but simply because of their underlying physiology. For example, if you have what's called low renin hypertension, where your renin-angiotensin system is already suppressed, amlodipine might work less effectively because that system isn't driving your blood pressure up in the first place. Someone with high renin hypertension might respond better to an ACE inhibitor or an ARB. This is why medication management for blood pressure often requires trial and error. The first medication might not be the right one for you. The second might be better. The third might be perfect. But doctors sometimes give up too quickly, or patients give up too quickly, because they assume nothing will work. I'm also concerned about a phenomenon I've been seeing more and more, and that's the issue of undertreated blood pressure in patients who experience side effects. Let me explain what I mean. Patient starts amlodipine. They get ankle swelling. They feel dizzy. They feel tired. They go back to their doctor and say, "This medication is making me feel terrible." Doctor says, "Okay, let's reduce the dose or switch to something else." They reduce the dose, the side effects improve, but now the blood pressure isn't adequately controlled anymore. And instead of adding a second medication or trying a different approach, both doctor and patient sort of accept the situation. Blood pressure is sort of okay, not great but not terrible. Side effects are tolerable, not wonderful but not unbearable. And the patient continues in this half-controlled state for years, slowly accruing damage from blood pressure that's higher than it should be. This makes me crazy because it doesn't have to be that way. There are so many blood pressure medications available. If amlodipine causes intolerable side effects at an effective dose, there are alternatives. There are ACE inhibitors. There are ARBs. There are beta blockers. There are thiazide diuretics. There are combination therapies. The goal is to get your blood pressure controlled without making you feel terrible. If you're not there yet, keep working with your doctor until you get there. Now, I want to shift to a topic that many patients find surprising, and that's what happens to amlodipine in the context of kidney disease. This matters because high blood pressure and kidney disease often travel together. Many seniors have both conditions. Amlodipine is actually considered kidney-friendly in most cases. It doesn't harm the kidneys directly. It doesn't require dose adjustment for most patients with kidney impairment. But here's what your doctor might not have told you. If your kidney function is significantly reduced, if you're in stage 3 or stage 4 chronic kidney disease, amlodipine might not be the optimal choice for you. Here's why. ACE inhibitors and ARBs have been shown to be kidney protective in patients with diabetic nephropathy and other proteinuric kidney diseases. They reduce the pressure inside the glomeruli, those tiny filtering units in your kidneys, and that slows the progression of kidney damage. Amlodipine doesn't have that specific kidney protective effect. It might still be appropriate, especially if your kidney disease is not proteinuric, but you and your doctor should be having a conversation about whether a different medication class might serve your kidneys better in the long run. I'm also thinking about something I need to address directly, and that's the question of whether amlodipine causes cancer. This comes up periodically. There was an old study, the VALUE trial from 2004, that suggested a slight signal of increased cancer risk with amlodipine compared to other medications. But subsequent research and meta-analyses have not confirmed this finding. The consensus in the medical literature now is that amlodipine does not increase cancer risk. It's considered safe from that perspective. But I want you to know about this controversy because if you read something online about amlodipine and cancer, you shouldn't panic. The more recent evidence does not support that connection. That said, Every medication has risks, and amlodipine is not an exception. I'm not here to tell you it's completely safe and nothing bad could ever happen. I'm here to give you an accurate picture of what the evidence actually shows. Now let me tell you about the most important thing I want you to understand about amlodipine before we finish. It's about monitoring. Effective treatment with amlodipine requires ongoing monitoring. And I'm not just talking about checking your blood pressure with a home monitor, though that's important too. I'm talking about regular check-ins with your doctor, regular blood tests, monitoring for side effects. Specifically, you need to have your kidney function checked periodically. You need to have your electrolytes checked, especially if you're on other medications that affect potassium. You need to have your liver enzymes checked if you're also on statins. You need to be asked at every visit about ankle swelling, dizziness, fatigue, muscle pain, any new symptoms. You need to have your blood pressure checked at different times of day, not just in the morning. You need to track trends over months and years, not just look at single readings. So many patients treat their blood pressure medication like a set it and forget it proposition. They get a prescription, they take the pill, they assume everything is fine unless they feel terrible. But high blood pressure is often called the silent killer because it causes damage quietly for years without symptoms. If you're not monitoring effectively, you might be accumulating damage to your heart, your brain, your kidneys, your eyes without any warning signs. That's the real danger here. Not the medication side effects, though those matter. The real danger is uncontrolled blood pressure silently destroying your cardiovascular system while you think you're protected because you take a pill every morning. Let me give you the complete protocol for safe, effective amlodipine use. Follow this exactly, and you'll get the maximum benefit with the minimum risk. First, timing. Take your amlodipine at the same time every single day. You can take it with or without food. Some people prefer taking it in the morning because that's easy to remember. Others prefer evening because that's when they remember. Do whatever works for your routine, but be consistent. Second, monitoring. Check your blood pressure at least twice daily, morning and evening, using the proper technique we discussed in my other video. Yes, I have a full video on correct blood pressure measurement technique. I'll put a link in the description. Log your readings. Bring your log to every doctor appointment. Third, watch for side effects. Any new swelling in your ankles, feet, or face. Any dizziness, especially when standing up quickly. Any unusual fatigue or muscle pain. Any bleeding gums. Any palpitations or irregular heartbeat. Report all of these to your doctor promptly. Fourth, know your numbers. Understand what your target blood pressure is based on your age, your other health conditions, your overall cardiovascular risk. Don't assume your target is the same as everyone else's. Ask your doctor specifically what blood pressure goal you should be aiming for. Fifth, never stop suddenly. If you want to come off amlodipine, work with your doctor on a gradual taper. Sixth, be your own advocate. If your medication isn't working or if you're experiencing intolerable side effects, say so. Ask about alternatives. Don't suffer in silence. Don't accept inadequate control as inevitable. Seventh, review your entire medication list with your doctor at least once a year. Make sure there are no dangerous interactions. Make sure every medication you're taking is still necessary and still appropriate. Before I wrap up, I want to tell you about one more patient. Her name is Linda, 76, a retired nurse who had been on amlodipine for almost 10 years. She was one of those patients who seemed to be doing well. Her blood pressure was controlled. She felt okay most of the time. She took her pill every day without complaint. But at her annual physical, I noticed something. Her ankles were significantly swollen. She hadn't mentioned it because, in her words, I thought it was just part of getting older. Her gum tissue was visibly enlarged. She hadn't mentioned that either. Her kidney function had declined slightly from where it was 5 years earlier, and her blood pressure, while technically controlled, was still running around 135/85, which is higher than ideal for someone with her cardiovascular profile. When I really dug into her situation, we made some changes. We reduced her amlodipine dose. We added a small amount of a diuretic to compensate. We switched her statin to a different one that didn't interact. We scheduled follow-up monitoring. Within a few months, her ankle swelling improved dramatically. Her kidney function stabilized. Her blood pressure came down to a healthier range. And she told me she felt better than she had in years. She had been tolerating a suboptimal situation for so long because no one had ever really looked at the whole picture. That is exactly why I make these videos. Because there are millions of Lindas out there. There are millions of people taking amlodipine or any blood pressure medication who aren't getting the full picture, who are tolerating side effects they don't have to tolerate, who have blood pressure that's not quite controlled enough, who don't understand what's happening in their own bodies. You deserve better than that. You deserve to understand your medications. You deserve to have your side effects taken seriously. You deserve to have your blood pressure controlled optimally, not just sort of okay. And you deserve to have a doctor who takes the time to explain all of this to you. If this video has been helpful, if you're learning things about amlodipine that you didn't know before, I need you to do something for me right now. Subscribe to this channel because this is exactly what I'm here for. I'm here to give you the medical information that most doctors don't have time to provide in a 15-minute appointment. I'm here to help you understand your health better so you can make smarter decisions and have more productive conversations with your healthcare providers. Subscribe and hit the notification bell so you don't miss any of my future videos. And please share this video with anyone you know who's taking amlodipine or any blood pressure medication. Knowledge is power, and too many people are taking medications without understanding what they're actually doing to their bodies. Now, let me finish with some final thoughts. Amlodipine is a good medication. I've seen it help millions of people. It's generally well-tolerated, effective, and affordable. For many patients, it's exactly the right choice. But it's not perfect. It has side effects. It has interactions. It doesn't work for everyone. And it requires ongoing monitoring and management to be used safely and effectively. If you're on amlodipine, take it seriously. Know what you're taking and why. Watch for side effects. Monitor your blood pressure. Work with your doctor. Don't be passive about your health. Don't assume that because you take a pill every morning, everything is fine. Be engaged. Be informed. Be your own best advocate. And one more thing I want to mention before we finish. If you're experiencing severe side effects from amlodipine, especially things like severe dizziness, fainting, difficulty breathing, or chest pain, don't wait for your next appointment. Call your doctor or seek emergency care. These could be signs of dangerously low blood pressure or other serious complications. Don't ignore symptoms that feel extreme. Thank you for watching. Take care of yourself. I'll see you in the next video.